Good afternoon and welcome to the National Hispanic Council on Aging's virtual town hall about COVID-19 vaccines, addressing questions and concerns. My name is Christina Pacheco and I am NHCOA's Director of Resource Development and Policy. It's my pleasure to moderate today's virtual town hall focused on COVID-19 vaccines. Due to the ongoing COVID-19 pandemic, NHCOA continues developing innovative ways to engage, inform, and listen to communities we serve. For 52 years, NHCOA has worked to improve the lives of Hispanic older adults, their families, and caregivers. Even during a pandemic, we continue to work towards that mission. The U.S. Food and Drug Administration has approved 2 COVID-19 vaccines for emergency use. Vaccines to prevent the COVID-19 disease are perhaps the best hope for ending this pandemic. But naturally, people have questions and concerns. In an effort to keep our communities informed and to share timely, scientifically backed information, NHCOA's first event of the year is aimed at answering questions and addressing the concerns of our communities about these vaccines. NHCOA continues its dedication to disseminating timely and accurate information, while also creating culturally and linguistically sensitive spaces in which Hispanic older adults, their families, and caregivers can come together to discuss issues impacting their lives. NHCOA also strives to connect Latino older adults with local leaders, advocates, service providers, and policymakers to work towards solutions that address their community's specific needs. This town hall is one of those spaces. Today, it is my pleasure to welcome a panel of experts that will highlight the basics of the COVID-19 vaccines, how vaccines work. It will provide a perspective from someone who has taken a COVID-19 vaccine, COVID-19 research trials, specifically the Howard University COVID-19 Novavax vaccine trial, and others. Before we get started, let's pause to thank our sponsors, as this webinar would not be possible without their generous support. Thank you, Lilly, AbbVie, Pharma, United Healthcare, and Pfizer Foundation. To begin the virtual event, it is my pleasure to introduce the President and CEO of the National Hispanic Council on Aging, Dr. Yanira Cruz. She is one of the nation's foremost advocates and spokespersons for diverse older adults and has been recognized for her commitment and leadership on behalf of diverse older adults nationwide. Welcome, Dr. Cruz.
Thank you, Christina. And thanks, everyone, for joining us. Welcome to NHCOA's virtual town hall. As you know, the COVID-19 pandemic has caused much pain and suffering. We have lost loved ones to the pandemic, and our lives have also been dramatically changed as a result of COVID-19. The good news is that we now have a vaccine that can be controlled, that can help us to control the pandemic and this virus. The availability of a vaccine is, I think, one of the greatest accomplishments of last year. And now we must ensure everyone has access to the vaccine. We must make it available through health settings, through pharmacies, as well as community settings like churches, like community clinics, housing facilities, and other nonprofit organizations. We are aware that there are concerns and fears among many community members about the vaccine, and that's natural and it's normal. It's important, though, that those concerns get addressed and that they get addressed in a culturally and a linguistically competent manner. One way to address this mistrust and concern is to use trusted entities and leaders who are trusted by the community to encourage communities to take the vaccine and address any questions that might come up. Well, NHCOA will continue to partner with institutions to inform and engage community members and help make the vaccine available to everyone. In the meantime, it's important to continue to follow measures to prevent the spread of the virus. We must continue to use our masks. We must continue to maintain physical distance, with washing our hands often and avoiding crowds. We are very fortunate this afternoon to be here with a group of talented minds and committed individuals to share information with all of us. I want to first express our gratitude to the panelists for taking the time to joining us and making this a priority. We know how busy you are. And I also want to say thank you for everything you do each day to keep us healthy and to keep us safe. And with that, welcome everyone. Let's get started.
Thank you, Dr. Cruz. Vaccines are substances used to stimulate the production of antibodies and provide immunity against one or several diseases. Vaccines help people survive and have been in existence since 1796, when Edward Jenner invented the first vaccine to protect against smallpox, a contagious, disfiguring, and often deadly disease that affected humans for thousands of years. However, vaccines can only save lives if people are vaccinated. A vaccine that remains in the vial is 0% effective. Today, vaccination saves about 5 lives every 60 seconds by reducing disease, disability, and death from a variety of infectious diseases. Smallpox was deemed officially eradicated in 1980 thanks to the vaccine. Had we not had a vaccine for smallpox, it's estimated that one person would die from smallpox disease every 6 seconds. COVID-19 is a serious disease. In only 10 months, the SARS-CoV-2 virus infected over 78 million people across the world, killing more than 1.7 million. COVID-19 patients require intensive care in hospitals at a rate more than 6 times greater than patients during the influenza pandemic in 2009. Unfortunately, many of those infected with the virus are faced with sometimes severe long-term health impacts. Many impacts of this virus are still being discovered. Vaccines provide a possible path out of the COVID-19 pandemic, and it is therefore fortunate that scientists have now developed several vaccines against COVID-19. Those vaccines have been found to be highly effective against the disease, providing a protection level of around 95% or more. But let's hear more from our first speaker, Dr. Henry Pacheco, a renowned infectious disease physician and family doctor. Dr. Pacheco is the medical advisor to the National Hispanic Council on Aging. Today, he will speak about the basics of the COVID-19 vaccine. Welcome, Dr. Pacheco.
Thank you so much, Christina. Can you hear me?
Yes.
Oh, okay. Well, thank you so much for that kind introduction. I should correct you, but I'm not an infectious disease specialist, but in any case, I play one on TV. Let me go ahead and get started on this. If you don't mind, can we get to the first slide, please? All right. Well, one of the first things we want to describe for the general population is what are vaccines, and of course, and how do they work. Vaccine is a type of medicine that's made up of specific biological substances, which could be a virus and a bacteria or a bacteria that are either killed or weakened. As in the case in COVID, for example, the one we're talking about now, it's only a piece of the virus, the spike that has been massively produced in lab human cells and isolated and purified to make the vaccine, so that when it's injected into the human body, it helps to protect against the specific disease, in this case, COVID, by provoking the body into making antibodies against that particular biological agent. So that when you're exposed, when the individual is exposed to the real infectious agents, the body already has its defensive army of antibodies that fight the virus aggressively. As Christina Pacheco mentioned, these vaccines have been around for years, and they have helped us fight terrible diseases like polio, whooping cough, measles, tetanus, and various others that you're all familiar with. Mass vaccinations have eliminated smallpox from the planet, and polio has been eliminated pretty much from the Western world. I think there are still cases of polio in Pakistan and other places or some parts of Africa where it's difficult to immunize. And of course, every year they prevent thousands from contracting the flu, which we shouldn't forget is also a disease that causes some degree of mortality. And interestingly enough, the vaccine also prevents the number one cause of cervical cancer. So human papilloma vaccine is being given to young people, and it's definitely having an impact on cervical cancer. So vaccines play a very important role in our medical armamentarium. Next slide. Currently, there are multiple vaccines being developed worldwide. We shouldn't forget, although people may get suspicious how quickly we came up with a vaccine, we shouldn't forget that laboratories around the world have been already working on developing vaccines against the coronavirus, which is a family of viruses of which, SARS, MERS, and have been families. So scientists have already been working very hard all over the world to try to develop vaccines against this type of viruses. Currently, so there must be over 153 or so vaccines being worked with or developed in other parts of the country. Here in the States, we have two vaccines, the Pfizer and the Moderna, that have been currently approved by the FDA. FDA, the body that follows the strict guidelines and to approve or not a particular medication, in this case a vaccine. So we have Pfizer and Moderna that have been approved by the FDA. Others undergoing phase 3 trials, and as I think somebody will mention about the process. But AstraZeneca, then there's Janssen, Novavax, COVID vaccine. They have different ways of eliciting protection. The Russians are also working on their own vaccine. They've already produced one that's called Sputnik. It's been used in the Middle East and Latin America. Perhaps one criticism is that they may not be going the strict process that we are following here in the States. In the United Kingdom and Germany, they're using also other vaccines such as AstraZeneca. There's one particular vaccine that I'm interested in, which is produced by Vaxart. This vaccine is oral, so that should be easy to distribute and easy to implement, but it's still, I think, far away from being somewhat far away. By far away, I mean probably a few months from being accepted and by the FDA if it proves to be useful. But in any case, there are lots of vaccines. I'm not going to go through the phases, which is essentially a very rigorous process of developing not only the vaccines, but also of gaining acceptance and approval. And of course, the FDA, as I mentioned, is the center that's in charge of approving the vaccines. And they have done this. And after they've gone through all the process, there were no corners that were being cut. The process was very accelerated because we have, modern technology to achieve that. So that we have the miracle of having two vaccines now that have been accepted by the FDA and have been accepted also by the CDC and there are recommendations how they're being used. Next slide. Next slide. Can you hear me? Hello? Can you hear me? Can you folks hear me?
We can hear you. Yes, Henry.
Yes, Dr.
Can you next slide, please? Can you pass the next slide?
Hi, Dr. Pacheco. You can continue. We are fixing some.
Okay, I'd love to continue, except I don't have the slides in front of me.
Oh, okay.
Let me see if I can open them, okay? Let me see. I didn't, I didn't think that, I didn't calculate for that. I should have, but I don't have access right now to the slides. Let's see, maybe I do. Okay. Okay, I do. Where was I? Okay. All right, yeah. let's see, I discussed this. Okay. So what I'm going to do is do a side-by-side comparison of the Pfizer and the Moderna vaccine. Just very quickly, as you can see very easily, they are very similar. Pfizer, is about a couple of years younger that can be applied. They both have similar efficacy. Both require 2 doses. Both require intramuscular injection in the deltoid. The interval between the first dose and the second dose for Pfizer is 21 days, for Moderna 28. The inconvenience of Pfizer, it requires ultra cold storage, and that's a special system, special machinery that, special cooling mechanism that it can be expensive and nobody has it, and it has to follow very strict cooling process. So that's a bit of a challenge there. Whereas Moderna, it can just manage with regular cold storage. Pfizer is good for about 5 days after thawing, whereas Moderna is good for about 30 days after at room temperature. And there's some discussion on minimum dosages, 5 doses out. So you can see how the logistics is a challenge, because the localities that order them have to make sure that they order the number of vaccines that they're going to use. Let me see. Let me get into the next slide, which is side effects. One of the things that we have to understand about side effects is that here it is. Okay, never mind. Let me see. I'm getting confused because now I have opened my own slide here. Let me just close my slide, and I'll just go by what you have. All right. Now, important to discuss side effects, because the media makes a big deal out of side effects and often highlights what might be adverse effects that may have occurred with some folks. But I want to just mention that there are children and adults who take 1 dose of penicillin and they can have severe side effects. So this is nothing new for medications. Most vaccines have common side effects. I think we have a speaker who's going to discuss what was her experience getting vaccinated. As I said, side effects are expected and are a sign that the immune system is mounting an effect. Some side effects are a bit worrisome, very rare. I don't know the exact numbers. Is anaphylaxis, which is a severe reaction to the medication. These folks just need to get to epinephrine and maybe oxygen immediately. But that has not been widespread. And once again, it is not common. When you think of the millions that are receiving this medication, it's not common for anaphylaxis to occur. It occurs, as I said, even in children who get penicillin, ampicillin for the first time, or any other medication. So far, we know that we should not be given to pregnant or lactating women or children, because it just has not been studied in these folks. So maybe later on there will be some guidance on that. But currently, those are the categories of folks that should not receive it. There might be others, immunosuppressed folks, but essentially these are the important categories. Next slide. All right. Long-term effects. Long-term effects are also not known, because we've just started on this. But let's not forget that people who participated in the clinical trials before this was released are being followed, are being monitored. Also, let's not forget that everybody who receives a vaccine in the United States also, my slides are gone, but I guess I'll have to reopen mine. But in any case, everybody who receives a vaccine is entered, the medical record is entered into a record. It goes into a system of actually monitoring this, monitoring anybody who has an adverse effect. This is no different. So the system called VIRES is monitoring everyone who has an effect, some sort of adverse effect. The physicians and clinics should report to this system called VIRES, and they in turn will report to CDC. So we'll all be alerted if something does happen. And so And of course, obviously, every single individual that's currently received the vaccine is being entered into this system in case there is some sort of adverse effect. The duration of protection of this vaccine is not yet known. A third booster might be needed later. That is not known at all. But I want to give that, for example, the flu vaccine is needed annually, and of course, tetanus every 10 years. So there are some vaccines that are, not forever. Hopefully, that will be the case with coronavirus, but that is not known yet. So next slide, please. Well, so which vaccine should you get, Pfizer or Moderna? Well, the urgent message from Dr. Fauci and everyone who is, all the people who are involved in this, is to get the first vaccine that is available. Whatever is available to you, you get it. No sense waiting for something better or something different. I believe, and that if there's somebody there that knows better, please do correct me. The Pfizer vaccine is the most widely offered and used mainland. Just from anecdotal, I was told by my daughter that in Puerto Rico they're using mainly the Moderna. I imagine because it's hot and Puerto Rico has unstable electrical grids, so I imagine Moderna is safer to use there because of how it's not as delicate as Pfizer. But let's keep in mind that COVID is a very serious and very contagious disease. As Christina mentioned, there have been millions of deaths worldwide. 22 million infections in the United States in 2020, and 380,000 deaths last year. That's amazing compared to like the whole Vietnam War. There were 50,000 deaths, so it's amazing. Thousands have survived the COVID infection and have been left, with serious complications. Can you hear me? Hello.
Yes, we can hear you, Dr.
Oh, okay, because I could hear another voice there. So most vulnerable people to the virus, to COVID, are, of course, older adults and those with chronic diseases, diabetes, hypertension, immune deficiency. Current medications to treat those that have a COVID are very ineffective and marginally ineffective, and God forbid a person ends up in the intensive care unit in oxygen. It's very, very severe and very close to death. The only effective medication I can think of is monoclonal antibodies, which are hard to obtain, and they should be given at the very, very, very start of signs and symptoms on the patient. But as I said, these are not easy to obtain, this type of infusions, and they're given outside of hospital in certain centers. All righty. Next slide, please. Other considerations. Well, this is mostly curiosities, I could say, or some are important. Mix and match of different vaccines are being allowed in the United States, but not quite in the U.S. Nevertheless, if somebody doesn't know or the record is lost as to which one they received, I think they will be just given any of the two, and so far there seems to be not a problem. But ideally, you want to get the same vaccine that you got the first dose, the same second dose. The effectiveness of one vaccine over the other, as I said, has been studied. Eventually, other vaccines will be available. The current big challenge is logistics of distribution. The federal government is distributing throughout the various states, and within the states, the state and local localities have to find a way to make this available to the greatest number of people very fast. States are setting up their own priority lists described as phases, people who belong to the phase 1 and phase 1B and so on forth. That's how they're distributing and prioritizing. The best is to contact the health department or to go to the website to figure out where you fit in these phases. It's according to age and according to disease, according to your job, and where you can get the COVID vaccine. So best place always is check your health department and state or local. Next slide, please. As I said, the state prioritization plans. This example is from the state of Virginia. Just an example. And right below, I listed a website. It's from WebMD, where you can reach and get state-by-state guides. So you go there and you find your state, you click, and you'll see what the prioritization is. But in Virginia, for example, phase 1, healthcare professionals, residents, long-term facilities. Phase 1B in Virginia, people age 75 and over. And then the last phase, 1C, are people 65 and over. In District of Columbia or Maryland is slightly different. And I believe even now they are beginning to change these priorities. And so I wouldn't be surprised if pretty soon they'll say, just give it to anybody who shows up. Nevertheless, in some ways, the prioritization does make some sense because you want to get those who take care of people taken care of before anybody else. Next slide, please. We still need to defeat the pandemic. We can't just rely on the vaccine. So as Dr. Cruz mentioned, you want to definitely avoid crowds, wear a mask, wash your hands when coming from the outside, use sanitizer liberally whenever you're in contact with doors, doorknobs, and just anything in the outside world. Avoid shaking hands. Keep a physical distance of at least 6 feet, and definitely get vaccinated and continue with precautions even after vaccinated, because there's a lot that is not known. For example, we know that after vaccination, or it is known to some degree, that it takes several days, 10, 15 days or so, to have protection, 95% protection after the second dosage. So even after vaccinated, that person should still walk out with a mask and follow all these precautions. That picture that you see on the side is interesting. That is the protection, the protecting garb that doctors used in medieval times when they were dealing with the plague. It's a very interesting, very creepy looking mask that they used, but there was a logic for everything given the state of science in medieval times. Next slide. Well, that's it. It's the end. If there are any questions, well, just feel free to ask them afterwards, and let's move on quickly to the next presentation.
Thank you, Dr. Pacheco, and my apologies for the technical difficulties during your presentation. I want to remind all of our attendees that if you have any questions for our presenters, please type them in the chat box and we'll address as many of your questions as possible during our question and answer session. The World Health Organization states that vaccination is a simple, safe, and effective way to protect people against harmful diseases before they come into contact with them. It uses your body's natural defenses to build resistance to specific infections and makes your immune system stronger. Today, there are vaccines available to protect against at least 20 diseases such as tetanus, pertussis, influenza, and measles. Together, these vaccines save the lives of up to 3 million people every year. Our next speaker is Dr. Carl Thompson, an associate professor in the Department of Microbiology at Howard University. Dr. Thompson received his PhD in microbiology in 2006 and pursued his postdoctoral studies at VCU School of Medicine, where he was appointed assistant professor in microbiology in 2011. Since that time, he has successfully established an extramurally funded research program with a focus on bacterial genetics and molecular biology. His previous funding includes the National Institutes of Health, Howard University Medical Alumni Association, the Swedish Research Foundation. His research has focused on transcriptional and post-transcriptional regulatory mechanisms in E. coli, pseudotuberculosis, and Staphylococcus aureus. Today, Dr. Thompson will highlight the basics of how vaccines work. Welcome, Dr. Thompson.
Okay, thank you very much. I just wanted to check to see if everybody could hear me.
Yes, we can hear you.
Okay, great. Thanks, Ms. Pacheco, for the great introduction, and thank you, Dr. Cruz and the National Hispanic Council on Aging for inviting me. It's an honor and a pleasure to be here today before you to talk about the basics of how vaccines work. There'll be a little bit of overlap between my content and Dr. Pacheco's content, and possibly some of the content for subsequent speakers, but I think it's going to be all complementary. Next slide, please. So basics on how a vaccine works. And this is just my financial disclosure slide. I do not have any financial interests or investments in the companies that are currently developing vaccines or therapeutic products by brand name or generic form associated with treating COVID-19. Next slide, please. So this is just the outline of the short talk that I'm going to be giving. So I will start by reviewing COVID-19 and some immunity concepts. I'll move on next to vaccines in general and COVID-19 vaccine concepts. And finally, I will review a couple of COVID-19 vaccine frequently asked questions. Next slide, please. So COVID-19 is caused by the SARS-CoV-2. So COVID-19 stands for Coronavirus Induced Respiratory Distress 2019, and 2019 because we know that that's when it actually started, right, in China. So that's where the date comes from. So again, it's caused by SARS-CoV-2, and SARS-CoV-2, not SARS-CoV-2. SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. So SARS-CoV-2 is a virus that comes from a family of viruses that cause respiratory distress. Next slide, please. So it's thought that SARS-CoV-2 is spread by aerosol, and that's one of the reasons why it's highly advised that we wear masks. On the left there, you can see the structure. It's kind of a schematic cartoon of the structure of the coronavirus based on how it looks in an electron micrograph. And then we have a cross section below the complete spheres. And so that cross section just kind of shows you that, you know, what the components of the virus are in general. So you have the nucleic acid material, and then you have some of the structures there. And the, as Dr. Pacheco said, the spike protein is the main structure of interest that they've been using for the vaccines. So as far as aerosol spread, you know, a single sneeze can produce up to 10,000 droplets, and the virus can remain suspended in air. And that's true for viruses and even bacteria that are infectious in nature and can be spread by aerosol. Because this is a respiratory illness and the virus likes to attach in the respiratory tract, it can remain in the airways, and the spike protein actually sticks tightly to the structures in the respiratory tract on the surface. Next slide, please. So why has the global community been so severely affected by SARS-CoV-2? So we think that SARS-CoV-2 is a genetic variant of a virus that caused a previous outbreak in 2003, and that was basically your original SARS-CoV coronavirus. And the viral immunology, the molecular kind of viral evolutionary virologists suspect that there is a recombination event between bat and human SARS viruses. And so what that has resulted in is a new virus that has not been seen in individuals or entire geographic populations. And as a result of that, we end up with very low herd immunity, which essentially means that we have a population with little to no immunity to this pathogen. And so when the body hasn't been exposed to a virus before, or any other pathogen for that matter, it can actually overreact while trying to quickly incapacitate and expel the virus. And that's a concept from our immune system, based on a system from our immune system known as innate immunity. And it does this while learning how to create a specific strategy to target the virus with pinpoint accuracy, and that's through our adaptive immune system. Next slide, please. Okay, so I just kind of wanted to use an analogy here to talk about why we think, you know, people are getting sick, how it relates to the immune system, using the concept of accuracy and precision as an analogy. So what this schematic here is showing, it's basically an archery target. And we have several examples here, and somebody was using it for archery target practice, and somebody took all of the arrows out, and then they step back and they look at how well this person has done. And you can see that we have 4 possibilities here. So the person in A is hitting the target, and they're hitting the target all the time. The person in B is hitting, is reproducibly hitting the same place, but it's not hitting the right target. And then in C and D, they are basically not hitting the target. And in one of the cases, there's a little bit more reproducibility than the other. So in C and D, this is a good analogy of your innate immune system. So it requires a little time or prior exposure to actually act upon a pathogen. However, it can also cause disease when left unchecked. And we think that's probably what's going on here with COVID-19. Now, your adaptive immunity, it requires prior exposure and it requires some time. And that's actually where our vaccines are going to help us. It's going to help us train the immune system to act precisely. And of course, in the top right, which is not quite applicable to what we're talking about, but just to kind of give you some concept, something that is precisely targeting the wrong thing as it pertains to our immune system, we would call that autoimmunity. So that also requires prior exposure and time, but for reasons that are not clear, loses specificity. And obviously, if there's a lot of different examples of this, the most widely, I think, known example may be lupus. So yeah, so hopefully that analogy kind of gave you some good context there. Next slide, please. So this schematic is kind of showing the principles of herd immunity, social distancing, vaccination. So vaccination, obviously, as Dr. Pacheco said, is the optimal tool for controlling the spread of COVID-19. And we have three possibilities here on this slide. So we have no immunization, no social distancing, or number 2, we have no immunization, but we're using social distancing. And that's the main tool that we've been using for the past several months to try to slow the spread of infection. And lastly, we have our emerging tool, which is immunization. So you can see in the first possibility, the first row, when you have the onset of infection is freely passing amongst individuals. There's no herd immunity. It can spread very quickly. And in C, you're going to have some people that actually end up passing away and some people that actually acquire immunity, right? But the cost of doing it this way is that you have mortality that is unnecessary mortality, and that's actually unacceptable for all of us. In the second possibility, we have immunization and social distancing. Isolated individuals slow the spread of infection, and so we end up having we still have people that get ill, but we're decreasing the amount of mortalities. And lastly, when we have immunization, we're again going to be increasing that adaptive immunity so that the infection does not freely pass amongst individuals. It will lower the amount of people that are infected in reference to the top 2 possibilities, and hopefully the idea is that that will also lower mortalities. Next slide, please. So what is a vaccine? So a vaccine is a substance used to create an active immune response against a specific infectious agent. And a couple of possibilities for how, as far as what actively is used in your vaccine vial. The first one is that it could be a complete microbial or viral pathogen that has been incapacitated. So it has the structure, but it has lost its ability to cause disease. Secondly, it can be a component of a microbial pathogen. Next slide, please. So how do vaccines help us? So it helps us by working with our immune system. So the immune system is the immune system of the body functions to recognize and eliminate infectious agents or allergens that do not belong in our body. And the schematic on the right just kind of shows you how that is anatomically where it's located, and all that is involved in it. So you have lymph nodes and vessels and the thymus and the spleen and the intestines and the bone marrow. Now, the immune system can work with or without training. So without training, it can mount a vigorous yet non-specific response that responds quickly to get rid of a threat. And so this, again, is when I had mentioned before, your innate immune response. This is what we're kind of referring to. Yet, this can also harm the body if left unchecked. So you may have heard the term cytokine storm. It's been mentioned in the news when they're talking about COVID-19 as one of the events in the body that's actually precipitating the disease itself. Now, with training, the immune system can also mount a vigorous and specific response that is focused on removing the pathogen, and that's adaptive immunity. And that's what we want to happen, and that's much safer for us if we have that type of a response to a pathogen, and that's what vaccines will help us to achieve. Next slide, please. So this is a schematic just showing the common components of a vaccine. So you have your active ingredients, which is normally your viral or bacterial antigens. You can have adjuvants, which actually increase the immune response, because sometimes the active ingredients are not the best antigens. And then the other things are essentially additives that stabilize and prevent contamination for your vaccines. Next slide, please. So there are different types of vaccines right now. So we have mRNA vaccines, DNA vaccines, protein subunit vaccines, and weakened whole virus vaccines. And Dr. Pacheco, he went over this a little bit as well. So these are a few schematics of, in general, what those structures would look like. So we have the mRNA vaccines that is included in a lipid nanoparticle, and that is going to be your Moderna and your Pfizer. And we also have some companies that are emerging that are using a weakened adenovirus with S protein genomic material inside of it. And finally, we have our protein subunits vaccines that are being developed. And they are going to be injected in individuals as well. So, but the overall goal is the same. We want to directly or indirectly create a specific component of SARS-CoV-2 that trains the immune system to recognize SARS-CoV-2 when it is exposed, thereby preventing COVID-19. And we wanted to do this without causing disease. Next slide. Okay, so I have just a couple of frequently asked questions as I'm closing. So one common frequently asked question amongst the public is, will the COVID-19 vaccination make me sick? So, and Dr. Fauci has mentioned this a lot of times in his talks. He mentioned that some people may experience what we call reactogenicity. So this is your mild but natural reaction to vaccination. So this could be fever, headache, you could be feeling tired. And I think the things that can throw people off about this is that, you know, it can mimic mild symptoms. However, this is basically a sign that the vaccine is working properly because it is likely due to your immune system. You remember we talked about that innate immune response, recognizing the pathogen component. Now, because a complete functioning SARS-CoV-2 virus is not in your vaccine, the vaccine will not cause COVID-19. There have, however, been some adverse events reported, but they are not very common, and therefore the probability of them occurring is very low. One of the most common, well, not common at all, but the one that we have heard about is anaphylaxis, and this is a severe allergic reaction. Next slide, please. Will the COVID-19 vaccination change my DNA? And so this is a question that has been asked, I think, specifically directed at the molecular nucleotide, the genetic vaccines, the COVID-19 mRNA vaccines, and there's also DNA vaccines in development. And so there's some concern that these vaccines will alter one's genome, and that's just not the case. Your messenger RNA cannot integrate in DNA. So I have a schematic here on the bottom right that shows how genetic information normally flows and works together with each other. So you have DNA that goes to RNA, and then that goes to protein. And the messenger RNA can actually be converted to DNA, but that's only in very, very specific cases with a group of viruses called retroviruses, which SARS is not a part of. And as far as your DNA integrating, your DNA can only integrate when there are similarities, when there is similarity between sequences. And since your SARS-CoV-2 DNA is different from human DNA, this is not possible. Okay, next slide, or maybe that is the last slide. Okay, so conclusions. So SARS-CoV-2 is a novel virus not previously exposed to the vast majority of individuals and the global population, resulting in low herd immunity. And the immune system is responding vigorously as a result, resulting in COVID-19 illness and death. Vaccination is the best tool available as a solution to address this problem by training the immune system and increasing herd immunity. And there are many different types of vaccines with the same aim to induce an immune response to SARS-CoV-2 without causing illness. And I think that concludes my presentation.
Thank you, Dr. Thompson. Again, I want to remind our attendees and participants that if you have any questions, please type them in the chat box and we'll address as many as possible during our question and answer session. The COVID-19 pandemic has been devastating for Latinos in the United States and globally, but the recent approval of 2 vaccines brings with it hope. However, the vaccine only works if people get it. This is especially true for Latinos, who account for 18.5% of the total U.S. population, but experience a death rate of 31.9% when using weighted population distributions. Understandably, there is a hesitancy among some Latinos and others to get the vaccine. This hesitancy and uncertainty are not surprising given the history of transgressions by the government and medical communities towards Latinos and other racial and ethnic groups. In fact, trust in physicians and healthcare systems is typically lower among Blacks and Hispanics when compared with whites, and there is a greater perception of discrimination in healthcare settings among Blacks and Hispanics compared to whites. However, this fear and mistrust has to be overcome in order to protect our communities that have been devastated by COVID-19. Today, I will talk about my experience with taking the Pfizer COVID-19 vaccine. So I gained access to the vaccine early on under the Tier 1 designation for healthcare personnel, given that I work in a hospital. Prior to taking any vaccine, whether it's the Moderna or the Pfizer, everyone has to read and fill out a consent form. The consent form does say that you should not get the vaccine, whether it's Moderna or Pfizer, if you've ever had a life-threatening allergic reaction to any vaccine, currently have an acute illness or high fever, have a severe allergic reaction to a previous dose of the vaccine, or have had an allergic reaction to elements in the vaccine. So that's the polyethylene glycol or polysorbate. And they do screen for those prior to getting the vaccine. You're also provided with a fact sheet, and there is a different one for the Moderna vaccine. I got the Pfizer vaccine, and it does list, as previously mentioned by both Dr. Thompson and Pacheco, a list of side effects that are possible, including injection site pain, tiredness, headache, muscle pain, chills, joint pain, fever, redness, nausea, and just kind of generally feeling bad. Those are all pretty common, even with the flu vaccine. So I got my first dose on December 21st at 4:05 p.m. And I tracked this because I'll talk about later, I participated in a CDC project to track my side effects. So by the time I went to bed at approximately 11:30, I had had some mild injection site soreness, similar to the flu shot, but that disappeared within 24 hours, and that was really the only side effect I had experienced. Given that we are vaccinated in cohorts, they do a third of the department at a time. So that way, if people do not feel well, the hospital is not down staff. Some of my colleagues experienced headaches, tiredness, needing to take a nap that they probably hadn't ever had to do before. So kind of the same side effects that was listed previously. At the end of getting the vaccine, we did have to attest to getting the second vaccine, because that's really where the immunity starts to take hold, is through that second dose. I got my second dose on January 9th at 11:45 a.m. And within 3.5 hours, I had some pretty severe arm pain. This was much more severe than my first shot, but it wasn't unbearable. I didn't take any kind of pain reliever. I just kind of dealt with it. I had several colleagues who had gotten their second shot who had experienced fever and chills, headaches. And so prior to bedtime, as a preventive measure, I took Tylenol just in case I was going to have a fever come on. By 11 a.m. the next morning, my arm pain was gone. I never had a fever. I never had a headache. The only unusual thing for me was that I woke up at 4 in the morning and I was wide awake and ready to go for the day. And I'm not a morning person, so that's very unusual for me. I did participate in the CDC's program VSafe, which is a smartphone-based tool that checks on you after your COVID vaccine. So you go to the fact sheet has where you go to sign up for it, and it sends you reminders to check in and log your symptoms. And this really helps ensure that they are able to continue checking kind of side effects and make sure that the vaccine remains safe for everyone. It was a nice tool, and as you can see, it kind of provides the smiley faces. You can say how you're generally feeling today, and then you check and add your symptoms and side effects to that. It's very easy, very user-friendly if you have a smartphone. And get the vaccine. I would encourage doing that because you're just adding to the general knowledge about the vaccine. So at this point, again, if you have any questions about my experience, I'm happy to share that with folks. But let's go ahead and take a question from the audience. So we had one person ask about, are the people who get an allergic reaction, does that show right away? I will say that I had to sit for 15 minutes after the administration of my vaccine in the hospital. I know that we, on the day that I worked on our vaccine drive, had vaccinated 1,002 people. And on the Saturday prior to that, we had vaccinated an additional 900 people. We have had 2 healthcare providers have an allergic reaction. One person, it took them a little bit longer to come back, and they were seen in, they were sent to the ED because they were having difficulty breathing. But I will defer to Dr. Pacheco and Dr. Thompson if they've heard anything different. I know some sites, if you have a history of allergic reaction and get the vaccine, they do have you sit for a little bit longer. I think some have extended that sitting period to 30 minutes. Dr. Thompson, Dr. Pacheco, do you have any insight?
Well, I'm not a clinician, but I do know that generally anaphylaxis is supposed to occur within a very short period of time. So for example, if you know people that have had allergy shots, it's kind of the similar concept. And usually when you go to the allergy clinic, they want to make sure that as they're dosing you up, they're not giving you too much allergen that could actually cause anaphylaxis. So when you take those allergy shots, you're actually supposed to sit and wait for 20 to 30 minutes, because I think statistically that's the highest probability, that's the time frame in where there's the highest probability that anaphylaxis will occur. And if it hasn't occurred within that time frame, then I think it's much lower going forward that you're going to develop anaphylaxis. And usually, I think, and Dr. Pacheco can correct me if I'm wrong, they like to, well, not like to, but I think the standard treatment is epinephrine. Just like for people that have allergies and they walk around with the EpiPen just in case they get a bee sting or something like that. So where they're actually administering the vaccines and actually doing the clinical trials, they have preparations for that as well.
Yes, I agree, Dr. Thompson. One of the things that also for the general public, we should mention to kind of dissipate the fears that some of these reactions, even the anaphylactic reactions, are not that rare. We've had, in my practice, I have people who fainted after a routine flu vaccine with no more consequences. And some people, by the way, warned me. They said after vaccine, I usually faint, so we would actually lie them down, and right after the vaccine so that they wouldn't end up on the floor. But we got patients who fainted in the waiting room because we asked them routinely to wait about 15 minutes, 20 minutes for their after their vaccine. So that is pretty routine. And so, having people wait 30 minutes after the COVID vaccine sounds reasonable. And people who have frequent allergies, I knew someone who has, is allergic to everything, house dust, this and that, just all kinds of allergies. I always think there's some degree of precaution in making sure that, where they are given the vaccine, that you're not that far from a health center that has EpiPen, epinephrine, and God forbid, maybe even some, oxygen and some Solomedrol or something like that. Well, something that will block the allergic reaction immediately. But in general, I think most of this are being predicted by vaccine providers, so they always have something like that on hand. It's not an unusual thing, so it should not cause any unnecessary fear in the public.
And then, Dr. Pacheco, there's a follow-up question. If you're allergic to the regular flu vaccine, would you, by default, be allergic to the COVID vaccine?
I don't think so, except that, if you're allergic to a particular component of the vaccine. But I don't see that there has been any announcement that people with the allergy to the flu vaccine should not get it. Although, they do. There is a precaution about people who had allergic reactions to vaccines. Once again, probably it's a good idea to that individual to be sure that they get the vaccine in a very near or in a hospital setting or in a clinic setting where they have the necessary medications to get that person out of a potential anaphylactic reaction.
Thank you.
The bottom line is I'm not aware of the specifics.
Perfect.
Go ahead.
And then what about someone who is a cancer patient or a cancer survivor? Is there any indication that they maybe should not take the vaccine or that the vaccine would do more harm than good?
From what I've heard is that patients who are cancer survivors and even who are immunosuppressed to some degree should go ahead and just get the vaccine. Once again, these precautions that are being observed, such as the setting, is important. I think we have to put everything in context of how serious this disease is. As Dr. Thompson mentioned, it's not the virus that kills you, but it's the body's incredibly brutal reaction to an incredible fight that it puts up against the virus, what really does you in by damaging all your organs. So people who have received cancer treatments and all that, they're already people who have weakened body in general, so they may not do well if they get the virus, so if they get the disease. So putting it in the context of how serious this disease is, then some degree of risk, it's reasonable to accept. Nevertheless, though, when you do go and get your vaccine, be sure that you mention what is your status. If you're asthmatic or if you're, if you have previous allergies, it's a good idea to mention it to them so they can be alert or alerted and may, they elect to give it to you under other special circumstances.
Thank you. And then one more before we continue on with our speakers. I believe we are waiting for one of our speakers to join, so we may move forward to Mr. Lambrinos, if that's okay. But if someone were to provide the following testimony, what would your response be? I'm 60 years old and have never had a cough or cold. My daughter is now 33 and she has never had a cold or been sick. We have never taken the flu vaccine and afraid to take this vaccine because we're concerned it will alter our natural immune system, which has been great for us. What would you say to someone who provided that testimony?
Well, if I may get ahead of folks, I would like to hear from the other folks, but that comment, by the way, is not unusual from people who resist taking the flu vaccine. I've had a lot of friends, patients who said, oh, I've never been sick, never had this, never had a cold, so I don't think I need the flu vaccine, which is, okay. But the problem is that it's in some ways is playing Russian roulette, because COVID is pretty brutal. I mean, the flu in itself has some degree of mortality, and but usually if you get the flu and you get over it, well, you're going to be okay. But in this case, not only can you get seriously ill, but you can also have very serious sequela after the actual infection, weeks and months after, and God forbid you can die. So that testimony, it's a matter of luck. Some people get it. There are people who smoke cigarettes all of their lives. They're 90 years old. They're still smoking 2 packs of cigarettes. That person didn't get COPD or cancer, but that's the exception, perhaps.
Great, thank you, Dr. Thompson.
That's my answer. I'd like to hear other people's answers, please.
Yeah, I think Dr. Pacheco has characterized it very well. And I think, Ms. Pacheco, you also highlighted something that's really important as far as the history of vaccination in the country and how it's really benefited us. I think people have a short memory, and I don't know if it's a short memory or maybe not quite a good appreciation of history. Because, before a lot of vaccines came about, there was a lot of people dying from a lot of infectious agents. So I think that's one thing to consider. Number two, to Dr. Pacheco's point also, I know in conversing with Dr. Majou, she's mentioned to me cases where, they've had people come in with COVID that seemed to be very healthy, very strong, relatively young, not a great history of chronic illness. So why is this happening? I don't really know, but it seems like we're seeing a lot of that, and I think that would be the one thing that I would caution the person who's giving that testimony, and maybe Dr. Pacheco can elaborate on that based on what he's seen in his patient population. As far as people who've gotten COVID who may have been previously relatively healthy?
Well, first of all, I'm not seeing any COVID patients. I shouldn't, once again, impersonate the fact that I am not seeing any patients, any COVID patients. Okay. But there is, ample evidence, and there's even public evidence of people who are incredibly healthy, young, healthy. There's also evidence of young teenagers and kids who have gotten severely sick. I mean, there are even some celebrities like this young fellow Cordero, you know, who has been, we followed the progress of his disease over months when he was in the intensive care unit, suffering an amputation of one leg, and then had complications of every organ, and resulted in his death. Now, this individual was young and in his 30s, I think, and previously, a very healthy individual.
Well, I think that is a great segue into our next speaker, Mr. Jorge Lambrinos. The COVID-19 pandemic and the governmental response has created an atmosphere of mistrust and apprehension among many older adults and others. It is expected that many older adult African American and Latino Americans will be reluctant for a variety of reasons to be vaccinated. But in addressing this problem, we should not reinvent the wheel. Our next speaker is Mr. Jorge Lambrinos, a founding director of the Edward R. Roybal Institute on Aging at the University of Southern California. Mr. Lambrinos has been actively involved in the field of aging for more than 30 years, developing programs and services that benefit the aging community. Mr. Lambrinos is also a board member for the National Hispanic Council on Aging, and he will speak about vaccine distribution and lessons from the past. Welcome, Mr. Lambrinos.
Thank you very much, and good afternoon, everyone. And first, I want to thank NHCOA, the National Hispanic Council on Aging, for having this seminar. It is very timely and very necessary, given the fact that we're finding ourselves in a very dire situation, especially here in California, in Los Angeles County, where our hospitals are just being overrun and we're running out of bed space. And so it's becoming a very, very difficult situation. This COVID-19 pandemic has really created an atmosphere of mistrust and apprehension among older adults, especially minority older adults. That we have vaccines available to address this problem. Now that we have these vaccines, we can expect that many older adults and African Americans and Latinos will be adverse for a variety of reasons for being vaccinated. I say that because this phenomenon is not very much different from the problems we had getting older adults getting vaccinated for the flu and the pneumonia vaccines back in the 1990s. Today, more of us are getting vaccinated for both flu and pneumonia. So that problem has been sort of subsided, but now we are being faced by a new vaccine for the COVID-19. And my comment here, as was stated, was that we should learn from our successes and we should not try to reinvent the wheel. And we are trying to address how do we get our Latinos and African American and minority communities vaccinated for the COVID-19. I want to report on a study that was done back in 1996, and it was reported by the CDC on December 12, 1997, MMWR. In fact, you can go to the website and identify and get that report. It reported on a pilot project in Los Angeles designed to increase influenza and pneumococcal vaccination levels among Latino older persons. The purpose of the studies was to develop and implement community-based activities to increase vaccination levels among Hispanic and African American adults in Los Angeles County, California. This was a two-part study. The first part was to collect information as to what the need was, as to why were Latinos and African American older adults not getting vaccinated for the flu and the pneumococcal vaccine. And the second part was to then implement the interventions that were developed based on the findings of the first part of the study. What happened was that we were able to increase vaccination levels for the target groups, the Latino and African Americans, by more than 25% from the base numbers. That was a great success. And you can look that up by searching for the CDC MMWR of December 12, 1997.
Just using your speakers. Yeah.
And then 46C49/ and then the pages 1165 and 1168. But if you go to the December 12, 1997 MMWR and look for the Los Angeles immunization study, you'll find that, and you'll get a little bit of the background of the first project, the first part of the study. What the whole study entailed was creating a community consortium composed of LA County Health Department, community health clinics, other organizations and stakeholders involved in healthcare and immunizations. Part of the study, the first part, involved conducting phone interviews and holding focus groups to determine the reasons older adults were not getting their flu shots. I should also add that in follow-up activities, we found similar issues among the African-American population. The problem of vaccination was made worse by the memories of the Tuskegee syphilis experiment when we were discussing the African-American community. The most common reasons reported for both groups for not receiving the influenza vaccine was belief of no need for the vaccine. I don't need it. Why should I get it if I don't think I need it? Having no knowledge of the vaccine. I didn't know there was a vaccine for this. Not being informed by a physician or their doctors of the need of the vaccine. This was one of the greater reasons, because it's, well, my doctor never told me I needed it. So I implore any of you service providers that you need to make sure that your patients are informed and advise them of the need to get the vaccination. Another concern was that the vaccine would cause illness. I think that was reported. That was one of the questions that was asked a few minutes ago, that, well, what happens if I didn't want to take it because I have a good immune system and I'm not going to get sick. And if I take it, I am going to get sick. This was a very common reason. And also another reason was the ineffectiveness of the vaccine. I think that was for the flu vaccine. I think we've had a lot of information concerning of how effective the COVID-19 vaccines are, being 95 to 99% effective. So that should be an easy issue to deal with. Hispanics were more likely to report lack of transportation to vaccination sites. So we need to look at our own communities, and the inability to afford vaccination. Many of them thought that you had to pay for the vaccines and they could not afford it. So therefore, I'm not going to get it because I don't have the money to pay for it. They also reported among the Hispanics primarily that the health providers' lack of fluency in Spanish was one of the most reported reasons for non-vaccination. They didn't understand what the doctor was saying or what the nurse was saying. As I stated earlier, there's no need to reinvent the wheel because we have a study that was very effective in addressing the flu and pneumococcal vaccines. And that was primarily by trying to, if we replicate the project that we did in Los Angeles County, we should be able to get some of the similar results. Vaccine coverage and vaccination for COVID-19 will substantially improve among Hispanic and African older adults if municipalities, cities, or communities establish a consortium of representatives from the community, public and private healthcare industry, local political entities, and other individuals interested in, one, establishing a dialogue with the community to improve public awareness about the benefits of COVID-19, and two, determining the causes of underutilization of health services and poor vaccine coverage among older adults using the need assessment methodology, and three, formulating and implementing recommendations and solutions. These were the interventions. Once we did telephone interviews, focus groups, we gathered a lot of the information that gave us the reasons why older adults were not getting vaccinated. We took those reasons and tried to come up with some interventions that would try to mitigate those reasons that they had. In fact, one of the unique recommendations that came out of the consortium, out of the original project, was the drive-by shootings. And everybody laughed at the time when somebody recommended we ought to do drive-by shootings, especially in Los Angeles. But what that involved was having people just drive into their parking lots and putting their arms out of the car and getting vaccinated. Today, that's very common. Back in 1996 and 97, people thought that this was a sort of a unique way of getting vaccinated. So those are the kind of recommendations that came out that are still being implemented. The interventions recommended by the Community Consortium enhance vaccination levels in the ethnic minority community. And it emphasizes the usefulness of importance of involving community members in developing health promotion and prevention activities. That was the whole concept by the CDC when they provided the funding for the first part, and then in the establishment of the Community Consortium. I need to say that what CDC funded, what they provided monies for, was the first part, which was to do the focus groups, to do the phone interviews, and to do some of the basic information gathering. The second part of the project was creating the consortium and then having the consortium use their own resources to develop those interventions. And the logic of that was that if you create the interventions out of your own resources, you are more likely to continue using those interventions in the future. That's what we found out with the drive-by shootings. Because the feeling was that if we just provide funding for the interventions, once the money is finished, then you're not going to do the intervention anymore because, oh, we don't have any more money. By having the organizations, participating organizations in the Community Consortium, design these interventions based on the resources that they had, the likelihood was that those interventions would continue to be used in future years. And that's what we found, that that's been the situation. The Community Consortium works with local, state, and public health officials to remove the barriers to vaccination. One of the things that we found out was that there were some barriers created by the organizations themselves and by the health department, by some of the rules and that they had. So which created really an obstacle for older adults to get vaccinated. For example, data from the community assessment was used to customize vaccination services and community vaccination campaigns, educational mailings to the public in both Spanish and English about the availability of vaccination services. They were saying, we don't know about these vaccines. We don't know where to get them. We don't know what to do. We don't know if we have to pay for them. So by creating an educational campaign that was created by the consortium and used by the individual member agencies, improve the education level of the older adults in the target community. And we also got help from the Spanish television station in creating public service announcements about available vaccination services and where to get them. If we are going to achieve herd immunity, then we need to make every effort to reach the most vulnerable who are adverse to COVID-19 vaccine. That's being our minority communities. The CDC should make resources available to replicate the Los Angeles Immunization Project in areas of greater need. Likewise, will be any one of the pharmaceutical companies that might be interested in helping communities improve the vaccination levels among the older adults that are the most liable to be affected by the COVID-19 epidemic or pandemic. I'm open for anyone to ask any questions about the study that we did, and I'll be able to maybe explain to you a little bit more about how we conducted the study. But I believe that if we can replicate the study that was very effective back in 1997 and apply it to the COVID-19 problem that we have, I think that we're going to improve vaccination levels among our older Latinos and African-American community. Thank you very much.
Thank you so much, Mr. Lambrinos. Our next speaker is Dr. Siham Majoub, an infectious disease attending in the Department of Medicine's Infectious Disease Division at Howard University Hospital and Howard College of Medicine. Dr. Majoub is currently the medical director for the Center for Infectious Disease Management and Research. She is the principal investigator on several grants, including the Novavax vaccine trial at Howard University. Dr. Majoub has played and continues to play an instrumental role in addressing the COVID-19 pandemic. She is the lead physician for the COVID-19 Treatment Task Force and contributed to the Howard University's COVID-19 treatment guidelines. Dr. Majoub has served as the Infectious Disease and Infection Control Advisor for the Faculty Private Practice COVID-19 Task Force. She was also selected by President Frederick to be the Infectious Disease Advisor for the President Task Force for reopening Howard University. Today, Dr. Majoub will highlight the Howard University COVID-19 Novavax vaccine trial. Welcome, Dr. Majoub.
Thank you. Good afternoon, everyone. It's my pleasure to address you all today about our Howard University Novavax vaccine trial. I apologize, I haven't used this. Oh, great, you guys have my slides, wonderful. So this is the Novavax phase 3 clinical trial for COVID-19 vaccine at Howard University. This photograph is our chairman of medicine and chief chairman of medicine, chief medical officer. As a leader, she showed us that she went and she took her vaccine. Because a lot of our patients and the community and friends and families, they ask a question, okay, you take it first and tell me how it feels, and then I take it. So I think the idea about this photograph is that all of us have to be leaders in our communities and talk to our communities about the importance of vaccination, because we know this disease is going to go on with us. It's going to be with us for some time, and the only way out if we get the vaccine to get protected, because as you can see, treatment is not that great. So vaccination. So unless we relieve that and anxiety from people that vaccination is important, and we got vaccinated. Now I have my ID badge. I got the two vaccines, the 2 shots. So my ID badge has a sticker that says vaccinated against COVID-19. So I can proudly show that to my patients to show them the importance of vaccination. Next slide. So this is basically to compare and contrast the COVID-19 vaccines and describing basically our Novavax vaccine trial here at Howard University. Next slide. I have nothing to disclose, no financial disclosures. Novavax is a company. This is their biggest clinical trial, but they did have other vaccines in the pipeline. They had a seasonal influenza vaccine. They had an RSV, another virus vaccine, and combination of seasonal influenza, RSV vaccine, and also the Ebola vaccine. And now the big news is that they have the Novavax vaccine. Next slide. So it's a phase 3. So vaccine trials go in phases. Phase 1, you have a few participants or volunteers. Phase 2, more participants, and then phase 3. So now we're in phase 3. So this is, as we speak, is happening in Howard. So it's a randomized, we call it placebo-controlled study. Next slide. So what is the trial? In this company, they had trials in Australia and South America, and now they are currently enrolling in about 115 sites in the US and Mexico. In US and Mexico, and we are very delighted that Howard is the only site in District of Columbia and Virginia. So we just want to have send the word out, spread the word that there is a vaccine trial here at Howard. The randomization is 2-to-1. So what does that mean? That means that if you have 3 people who come to us in the research unit, of these three, 2 are going to get the vaccine and 1 is going to get what we call a placebo, meaning like a saline injection. They get 2 shots 21 days apart. So I just have to again stress the point of randomization. So 2 to 1. So my patients ask me, Dr. Majoub, why do you want me to be in a clinical trial? Because even though we have 2 vaccines under emergency use authorization, the Moderna and Pfizer, they are not available for everyone. They're available for healthcare workers, for nurses. They're going to be available for people who are maybe in nursing homes, and other, people who are first responders. So it's not going to be available for everyone very soon, for month and month. So when you are in a clinical trial, your chance of getting the vaccine is high. Maybe like I said, 3 people come in, 2 of them can get the vaccine. The follow-up is up to 2 years. So this is just, again, send out the message in the community. Howard will take good care of these people. It's not just we give you the shot and we send you out. If we find out during the screening visit that there is anything unusual, like your blood pressure or something, we will refer you to either ask you to talk to your primary care doctor or refer you within Howard so that they can take care of your other medical problems. The outcomes is that they want to see if any COVID cases or severe COVID cases happen during the trial, people who getting the vaccine versus not. And the secondary outcomes is just they do some immune biomarkers and basically checking for side events, side effects. Next slide, please. So why the Novavax trial? Because we are trying to include people of color, Latino, people who work the hard jobs, people who live in condensed living situations, people who are working in condensed working environments, because this is the virus has affected these communities the most. I can tell you, I work in the clinic, I do clinical trial, and I'm also in the hospital. I see COVID patients. The most people we see are the African Americans, people of color, Latino, people who have underlying comorbid conditions, people who have diabetes, high blood pressure, elderly people. These are people who have been hit hard by the virus. So we just want to increase the diversity because the history tells us, like, people of color, Latino, they don't participate in clinical trials because of fear, because of mistrust. But now a very important message to go out in the community. This is all done, even though it's a Novavax, it's a sponsor. It's a company, pharmaceutical company, but everything is under the supervision of the FDA, the Food and Drug Administration. They do a lot of review, and the FDA does not cut corners. They have to make sure everything is safe. So safety is a very important word that people in the community have to hear. And this is what I keep repeating here in my clinic. Next slide. The primary endpoints for this study is just to prevent people getting symptoms or confirmed COVID, and either mild disease or severe disease. Next. So who do we want to enroll in this study? The participant has to be 18 years of age or older. And then they have to be able to have to give a consent. We want to include people who have, like I said, who are at high risk for getting this infection. If there is women of childbearing potential, they must agree to be inactive for at least 28 days prior to the enrollment and up to 3 months after they last shot vaccination. They can have diabetes, they can have high blood pressure, they can have asthma, but they have to be stable, because if they are not stable and they get on the study, then you don't know if they get sick. Is it the shot that gave them the sickness versus, anyway, they were going to get sick. And they have to agree to be in a clinical trial. Next. The exclusion criteria is someone, like, let's say if you have someone who is hypertensive and their blood pressure is always up, they're not taking their medication, they're not stable, that's not good. Anyone with diabetes, they can be in the study, but this diabetes have to be stable. They cannot be having high sugars all the time, or their monitoring labs are high. HIV patients, we are enrolling HIV patients if their CD4 count has been more than 200. Anyone who had COVID, that's an exclusion. We cannot have them in the study. Also because this is like the flu season, so we're vaccinating people, so we have to make sure that the people, what time did they get the flu shot? They cannot get the flu shot within 4 days before or 7 days after the vaccination. Immunocompromised, meaning people with cancer or other immune deficiencies. They can be a cancer survivor. Let's say a woman with breast cancer, but she took her chemo, radiation, everything, she's fine. She can be in the study, but we cannot enroll people who are actively taking chemotherapy or radiation. Also, we cannot put people in the study if they're receiving immunosuppressive drugs. After these vaccines are approved, then they will run these studies in these immunosuppressed people. Next slide. So I've spoken about active cancer. People who are breastfeeding or pregnant or who plan to become pregnant within 3 months following the last visit of vaccination. So basically, we want to avoid anything to happen to the baby, so these people are excluded. The study team member or first degree relative like myself or my family cannot be in the study. Current participation in other COVID-19 clinical trial. We want to make sure that they get one vaccine, they don't get 2 vaccines. And the big question is going to be, okay, Dr. Majoub, so I participate in your trial. What if in my workplace I get offered one of the emergency use authorization vaccination, the Moderna or the Pfizer? That's fine. There is a protocol. Most likely they will. Now the participant is blinded. I am blinded. My co-investigators are blinded. We don't know what the participant is getting, to avoid bias. But if the participant, their workplace gives them vaccination, offers them vaccination, then there is a protocol so that these people can be unblinded, so they know, because if they are getting the Novavax vaccine, then it might be a problem to give them another vaccine. You don't want to give them 2 different vaccines. Better to stay and take one vaccine. Next slide. Okay, so we really appreciate you guys referring your patients. This is the phone number to call, 202-865-7743. Please take a screenshot of this slide. It's very important. You can see here on your right-hand side that we want people who are age 18 or older, people who are most likely at risk to be exposed to COVID-19. These are people who are underlying medical condition. Remember, diabetes, high blood pressure, but stable, controlled, not out of control. People who can be exposed in their jobs, working at Target, Walmart, working at different sales places, people who are construction workers, people who are painters, people who just are exposed to the communities, people who are 65 and older, people who work in jails or prisons like security guards, people from, of course, racial, we have spoken about that, people who are Black, African American, Latino, American Indian, Alaskan Native, Native Hawaiian. So please call 202-865-7743. This is very important. This is historical at Howard. We're trying to help our communities by spreading the word and telling them that we have a vaccine trial, because that's the only way out of this, is that we get a vaccine and get protected. I think this is my maybe last slide. Basically, this is what I have spoken about. We're going to, a lot of participants asked about the emergency use. There might be a possibility, something called crossover. So what does crossover means? Means that someone is randomized to get the vaccine and someone gets the placebo. So when the crossover happens is that at one point, the people who got the placebo will get the vaccine. But still they don't know, still they're blinded and blinded. But this makes people feel better that, like, even though they're participating in a clinical trial, in the beginning they might not take get the vaccine, but then towards the end they do the crossover and they can get the vaccine. So this is something that they're working on as well. Thank you very much. I hope I didn't go over my time, and I will be happy to take any questions, I think, later on.
Hello, this is Senator Pacheco. I had a comment for Mr. Joe Lambrinos' presentation. Is this a good time or are we off?
You can go ahead.
Okay. Yeah, it was a very interesting presentation. I think one of the things we have to consider is that in general, increasingly social media is one of the biggest stumbling blocks that we have to dissemination of good information and appropriate and science-based information about vaccines. I think social media tends to amplify myths and controversies and mischief. So that for every entry from the CDC or some knowledgeable individual institution into social media, you have 5, 6, 7, 10 entries from people who are just creating a confusion and havoc. So social media, instead of being a friend, is getting to be a very difficult way of disseminating information about vaccines. Secondly, about Latinos, Latinos, although the percentage of Latinos that are immigrants is not as high as people think, but in any case, Latino immigrants should have a memory of incredible efforts in their countries to have a population vaccinated. I mean, vaccination crews from health departments go door to door and vaccinate everyone there and mark the house with an X where everybody has been vaccinated. The only ones who run away are children, and I know that because I was one of them. So they go door to door and vaccinate everybody. So Latinos who have some memory of the old country should know that vaccines are good, and the country tries to vaccinate everyone. So we should probably capitalize on that and making sure that they remember how vaccinations and how important. And there's been no mass. There's never been a mass of people who objected to vaccinations traditionally in Latin America. Now, the other problem we have is perceptions. For example, the idea is to vaccinate folks that are minority, African American, Latinos, because the mortality rates and infection rates among them is very high. Part of the reason is because, well, they work in service industries and they're exposed to a lot of people, and they may live in crowded homes because of social, poverty and this and that. And so they were, some consider that they should be among the first groups to be vaccinated. Well, when that happened, others twisted this around and made it like, oh, they are going to experiment on Latinos and African Americans. That's why they want to give them the first shot. You see how news can be turned on its head. Lastly, just today, there was a comment about a physician, an OBGYN, it was in Yahoo, that got, I can't remember, but some serious blood condition about 2 weeks after getting the vaccine. Now, that is getting to be, it's in the first page of Yahoo. Yet the probability and the possibility is very high that there's no relationship to the vaccine. It's a coincidence. But that will get amplified. So we have a lot of work to do. So Mr. Lambrinos' suggestion that we should disseminate in an orderly manner in the communities is very important, because we have to neutralize social media. I'm sorry to say that. And people should be urged to get their information from their health departments, essentially, well, the health departments, if they have access to internet, well, from the CDC and places like that, but not from, Twitter or Facebook or something like that. This is my comment.
This is Jorge. Let me make a comment. I think you're quite right. One of the things that we found in the study, it wasn't so much that the Latinos were adverse of getting the vaccine. Their problem was more knowing where to get it, how much it was going to cost, and those kinds of issues, transportation issues, because we found a lot of them were using injectionists. They were very familiar with injectionists back in their countries where they got their vaccinations. I remember when I was in Panama, every time I went to the doctor, I got some kind of a shot in my arm. So it was nothing unusual. So the problem with the Latinos was lack of access, lack of doctors advising them to doing it, the cost, the fear of cost, and lack of knowledge about it. as opposed to the African American community, that there was an adverse reaction to actually getting vaccinated because of the Muskegee experiment.
Right. Oh, 100% I agree with you. One thing that I should mention lastly is that we should not, we have failed to indicate that this vaccine is essentially free because it's been paid by the government with our taxes. So we've got to make sure that people know and understand that it's free and avoid any scams or anybody who's trying to charge them. You know, physician offices may charge, you know, a small fee for administration, but they can still get it free. So it's, thank God it's a free service, the vaccine.
I would like to add just a little bit to the discussion. It's a great discussion. I don't have as you know, as much intimate knowledge about the Latino community as the other panelists, but I will say that well, my parents are from the Caribbean. They're from Jamaica, West Indies, and so there's some similar cultural things there going on. But I think my comment is more related to just science education in the country and how important that is. You know, you hear these comments sometimes from people that say, you know, why do I need to take biology, or why do I need to take chemistry? You know, why do I need to take physics? Why do I need to understand these things? And I think now we're kind of seeing the detriment of that mindset, you know, because when people are not aware of some of the basics, you know, and sorry for that beep in the background, some of the basics and the things that we can learn in K through 12 or pay attention, or even really the educational system pushing it, then it creates a vacuum whereby this information can really grow and spread and multiply. So I think this is also a great opportunity for us in the African American and Latino community to really encourage our children to increase their science literacy, to really pursue science, think about pursuing science, medicine as a career, healthcare as a career, and even for those who are not in school to really challenge them to, you know, to read up on these things. So if you haven't taken biology or you haven't taken chemistry, you know, there are ways that you can find reliable sources of information on biology, microbiology, virology, immunology, and really learn. I mean, I think that's the good thing about the information age, is it's so easy to become an educated consumer nowadays. And I think there's information at various levels of ease and difficulty to really cater to anyone. So that's all I wanted to add to that.
Thank you, Dr. Thompson. There is a huge push through the National Hispanic Council on Aging to really encourage and work with institutions to create pipelines for Latinos and other communities of color to really get into the STEM field. So we definitely second the comments of our panelists. And I'm sorry, Dr. Pacheco, did I cut you off?
No, I was just saying absolutely to the previous speaker. That's Thompson.
Perfect.
Sorry.
We do have a question from our audience, and I think it kind of goes in line with the current discussion. So do you have any specific messaging that advocates can use to ally concerns in communities that have been targeted, and this is going to focus more on immigration, but by the public charge rules? Communities that might be more hesitant to take part in a government vaccine rollout program for fear of being counted as having used public programs in an anti-immigrant kind of veil that we're living in.
Well, that's a great question, and I think probably you, Christina, who have a legal background, can answer. But I tell you, just one little addendum is that, as you know, there was a congressman who said that those illegal aliens, mostly Latinos, working in meat packing houses were not going to get the vaccine. I think that was a great step, you know, not realizing the effects of having a large nucleus of people unvaccinated. So, yeah, that's something that you should probably answer.
This is Jorge. We had the same situation when we were doing the one for the flu and pneumococcal, and the way we dealt with that was getting the county health department, which was a member of the consortium, and the community health centers and the other ones actually put out a very, very strong message that their the issue of immigration status was not going to be held against them. So it was more important for them to come in and get vaccinated, and no consequences would be derived from their participation. So it needs to be a very strong statement from the city or the municipality or the county health department or city health department to make a very strong statement that that's not going to be it's not going to affect them, in order to make sure that people feel comfortable in participating.
I would concur with Mr. Lambrinos. I have not heard anything about this being quote unquote counted against somebody under the public charge, given the population health benefit that comes from immigrating or immunizing folks who live in our communities. As far as I know, here where I live, they're not collecting any kind of identifying information with regards to social security numbers. I did have to give my date of birth and my email address so that they could set up the appointment for my second dose, and my name. And that was the identifying information that was collected. I do think we as advocates and community-based organizations need to ensure that they work with their communities and the health departments who are distributing these vaccines to make sure that there is strong messaging out there that this will not affect someone's status, or that there will be no linking for immigration purposes. And so for the community-based organizations that are on the phone, I strongly encourage you to take on that role in your communities, because that is a big concern.
This is again from Howard. Dr. Majoub, you may be more familiar with me than with some of the things that we have in place concerning that. Do we have information to address that as far as Howard in general in the COVID trial, if you're still on? Okay, she may have had to step off. Okay, but I do think I'm sorry, those are some things that we actually have discussed in our community advisory board meeting as it pertains to the COVID-19 trial. And so I do think that that at Howard and as it pertains to the COVID-19 trial, those are some things that we are acutely aware of as we are reaching out to the Latino community.
Thank you. We had another comment question come in, and I want to encourage our attendees, please, even if you don't have a question, but maybe have a comment, go ahead and add it to the question and comment box. If we're not able to address it on this session, we do get a transcript of those questions, and we'll work with the panelists to have those answered and posted on our YouTube channel with this recording. So the next question is, I'm a case manager for family caregivers of older adults, and most of them don't want to get the vaccine because they're afraid of the unknown long-term side effects. How would you encourage them to get vaccinated?
Well, let me just chip in on that. Yeah, let me just chip in on that. You know, you have to be very tactful because the fact is that we don't know what long-term effects might be. I mean, you want to be truthful. You want to say, well, there's none. But they are being studied. However, we do know the effects of getting the COVID virus now. We do know, and especially for older adults, the possibilities of death or maybe even worse, disability are very high. So let's compare an unknown, which we don't know, long-term effects, against a known, which is that the virus, the COVID, presently will cause havoc, destroy a person's body. And I tell you, it's a very horrible way of dying of COVID. I mean, you don't want to die in an intensive care unit being intubated for weeks or less. So It's that. It's playing the unknown versus the known.
I would just like to add again that, and not being a clinician, but my observation is the age group over 65 seems to be severely affected by this as far as incidence, morbidity, and mortality, as Dr. Pacheco has said. So I think that is something for them to really seriously consider.
Yeah, this is Jorge. Again, when I talked about the community consortium, the main job of the consortium was to educate the community. And every community is different, so we can't just do a cookie cutter thing. So that's why it's important to create a local community consortium that knows the community and addresses specific problems. Let me make a statement that on the study that we did, it was targeting Los Angeles County, primarily the Latino community that reached LA. We also had a control group and a similar community, same size Latino community. And when we did a comparison, we did increase by 25% or more in the target community, and that increase was not reflected in the community that did not have a community consortium, because those initiatives or interventions were not applied to the control group. Therefore, it's important that each community develop their own interventions that apply to their specific community, so that it becomes a lot more effective. And there was a point discussed about social media. When we were doing the study, social media was not available. So there's a way that we could use social media in a positive way in order to make sure that we educate the people, primarily educate the young people, who will then pass on the message to their parents or grandparents. Now, I sort of had a chuckle when we were talking about the effects of the vaccine long term. I'm 76, so the whole thing of being long term is kind of relative for me.
Thank you. I do want to share that we did get information that the Novavax vaccine clinical trial does have a phone line in Spanish. They have bilingual study team members to help include Spanish and those with limited English proficiency. And they do not ask about immigration status, social security numbers, or financial status. Again, before we end, if you have questions and or comments that you want to share, please include them. If we were not able to answer your question during our time, we will ask our presenters and others to provide written responses that will be posted online. Before ending the webinar, I would like to introduce Dr. Mike Ibada, a board-certified emergency physician and the Vice President of Medical Affairs and Strategic Alliances at Pharma. In his capacity at Pharma, Dr. Ibarra leads stakeholder outreach on federal health policy issues. In addition to his work at Pharma, Dr. Ibarra works clinically in the emergency department at MedStar Georgetown University Hospital. He will provide closing remarks.
Yeah, thanks for having me. Can you hear me okay?
Sure can.
Yes.
Yeah.
Awesome. Well, thanks so much for having me. I've really enjoyed listening to all of the experts on this panel. My name is Michael Ibarra. I'm a vice president and chief of our medical affairs function at Pharma. We're the trade association. We're based in Washington, D.C., and we are working on behalf of our membership that includes the leading innovative biopharma companies in the U.S. and around the world, including companies like Pfizer, J&J, Eli Lilly, Gilead, companies that are really on the forefront of developing therapeutics and vaccines against COVID-19 and many, many other illnesses that are infecting patients. In addition to my role at Pharma, though, I'm also an emergency physician. I work in D.C., not too far from my colleagues that were on earlier at Howard. I'm at Georgetown, across town in Washington. And since the start of the pandemic, I've been practicing in the emergency department. I've become a COVID emergencyologist, as many of us have, because we all need it to be. We all need to know how to diagnose, treat COVID-19 in the clinical setting, but then also work on the policy areas that impact the pandemic during my time at the virtual office at Pharma. So this has been a really great session, and I'm happy to close it out by saying that We're definitely at an inflection point. The pandemic is surging. Cases are as high as they ever have been. I worked last Friday night. I do 1 shift a week in the emergency room, and as I do on most Friday nights, dealt with a lot of COVID-19. Intubated a patient who was in respiratory failure, put them on a ventilator, and that was an example of someone very, very sick. But then also I was able to take care of patients that were earlier in the course of the disease. And a positive note, was able to offer them new therapies, these monoclonal antibodies that hopefully will help them and prevent them from needing to be hospitalized down the road. And that's because we're at this inflection point that shows us the most concerning time in the pandemic, but also the most promise in the pandemic. We have highly effective vaccines and highly effective therapeutics that are in the toolbox for providers. We have antiviral medicines like remdesivir that's given to hospitalized patients, and more companies looking at other antivirals like pill forms or inhalers that could be given to people at home. We also have monoclonal antibodies, these immune systems in a bottle that have been shown to reduce the rates of hospitalization when given to patients early on. We also have anti-inflammatory medicines that help patients overcome the later stages of illness. And of course, we have vaccines. There were 2 that have emergency use authorizations, one from Moderna and another by one of our member companies, Pfizer, that are upwards of 95% effective at reducing symptomatic COVID-19. And that is truly, truly remarkable. I was able to participate in this process myself. In the summer, I signed up on the coronaviruspreventionnetwork.org. That's coronaviruspreventionnetwork.org. It's a website that's still up, and I would encourage folks to go take a look and sign up if you're interested. I put my name in the hat and was contacted by University of Maryland to see if I was willing to participate in the Moderna clinical trial. So I got 2 shots, one in August, one in September. Went for many follow-up visits. I filled out daily journals to see how I was feeling. I found out in December that those 2 shots were placebo shots, not vaccine. So at the end of the month, I was able to get my first dose of an EUA vaccine. So I was glad to be able to participate to move the process forward. I got a lot out of it, and I learned so much about the process of clinical trials and what we have to do to make them more accessible to communities. And yet we face a challenge, a vaccine, of therapeutic hesitancy that everyone spoke about on this panel so well. There's slow uptake of both vaccines and of therapeutics. There's pandemic fatigue. And then there's the on-the-ground reality that providers are overwhelmed and exhausted. And that's been shown to me in very stark terms. These monoclonal antibodies, for example, they're hard to pronounce. They have complicated names. They're hard for clinicians to describe them to patients in simple terms, and physicians are not always comfortable answering the tough questions that patients might ask. And the same is true for vaccines. The industry is doing everything that we can to quickly, safely develop these tools, manufacture them to the highest standards, and distribute them efficiently. And that's really where we exceed. But we're also stepping up to help develop tools that help us get these medicines to patients that need them, and vaccines in the arms of every American that's eligible to receive them. So for example, pharma is proud to support the launch of the Partnership to Fight Infectious Diseases Vaccination Initiative. I would encourage folks to look at that website. It's focused on 3 core areas: safety and efficacy, the equitable distribution, and then also overcoming vaccine hesitancy in communities of color. They've developed a number of tools and resources that I think will be helpful to you and all of your community. So with that, I thank you for this opportunity, for the ability to participate, and thanks to the panelists that were excellent speakers and experts, the National Hispanic Council on Aging, for hosting this great event. Thanks for having me.
Thank you so much. And thank you to our sponsors, experts, the attendees for joining us for today's virtual event. For more information about today's virtual event and our upcoming virtual events, please visit our website and social media channels, Twitter, Facebook, Instagram, all at NHCOA. It's everybody's job to work towards stopping the spread of COVID-19, and it's our duty to comply with public health guidelines, such as wearing a mask that covers both your nose and your mouth, practicing physical distancing, and washing your hands. Let's be agents of change. Let's do it for our family, friends, older adults, and our communities. Hope is essential in times like these, but let's remember that you are not alone, and together we will succeed. The heart of NHCOA goes out to each of you. Thank you, and until next time, goodbye.
Thank you.